Okay, good afternoon. Thanks, everybody. Thanks for being here today, late in the afternoon on a gorgeous day. I'm going to talk to you today about the ways in which we have integrated an online single session pain class at the Cleveland Clinic. I'd like to present sort of the pathway that we have taken to make this class part of standard of care, as well as our exploration. We started to explore several different questions related to how this class might impact engagement in other pain behavioral interventions within our center. So the only disclosure I have is that I am a certified empowered relief instructor and on their faculty. So I do deliver educational workshops on the empowered relief class, which is the single session class that I'm going to be speaking to you about today. That was developed by Dr. Beth Darnell at Stanford, who spoke about that. I believe it was at 1 o'clock today. So hopefully some of you had the opportunity to hear some of the great things that she's doing with that class. So like I mentioned, I would like to present to you a very pragmatic application of this behavioral health, very brief intervention within our chronic pain center. We have made it part of standard of care. And so I'll speak to you a little bit about the process that we undertook to get to that point. We also want to look at the impact of attendance in this class on engagement in additional pain behavioral programs or interventions that we've recommended. And I'll talk a little bit about some of the clinical outcomes that we are starting to see in some of the preliminary data that we've been looking at. So just to kind of give a broad overview, we do know that there is a call to action to deliver more brief pain behavioral interventions, knowing that this can provide greater access to patients maybe that haven't received it thus far. And in 2019, the Health and Human Services did release a report that recommended brief behavioral pain treatments and did also highlight empowered relief by Dr. Darnell and also My Surgical Success, which was a digital application of that class for the surgical population. The purpose of this session is not to go into depth on empowered relief or the efficacy for that particular class, but what I will say is there is a lot out there. It's being demonstrated to show improvements in a variety of different populations, both surgical and chronic pain. So kind of knowing those two factors, that we know that brief intervention can be valuable, that there is this class that is providing evidence of benefits, we wanted to see how we could operationalize this within our chronic pain team at the Cleveland Clinic. And we also know that engaging patients in behaviorally based pain care can be difficult. There can be skepticism, apprehension, variety of reasons for dropout. And we have experienced that along with probably most everyone who has tried to implement behavioral pain interventions. So we wondered if patients engage in this class, would it make a difference? Would they be more receptive to additional pain care that's behavioral in nature? So the project was initiated pretty much in conjunction with the onset of the COVID pandemic. We had identified at that point a need to be able to offer something quickly to our patients because we very abruptly, as everyone else, stopped doing the in-person care. And so we started to deliver this class to pretty much all of our chronic pain patients that we were seeing as something that we could give them right away. We could see groups of patients. They only had to come once. It was something that was, not too burdensome on them to sit through and to learn a little bit about how to manage their pain. So this is all operating within a multidisciplinary team at the Cleveland Clinic, the Center for Pain Recovery. We have behavioral pain specialists, a pain physician, psychiatry, APNs. We also work very closely with physical and occupational therapy. This is just an overview of kind of the different treatment pathways within our center. The thing to know here is that we receive internal referrals from the Cleveland Clinic as well as external from all over. But when a patient is coming into our center, they have been identified as a chronic pain patient, typically very complex, refractory to conservative treatments. They are initially seen by either our pain physician or a pain psychologist. Now, if they see the pain physician first, he has a very incredible role in sort of selling the patient on our model of care. And he always refers to pain psychology. So every patient that is seen by him is then automatically referred to one of our pain psychologists or behavioral health workers that are trained in pain. And there's a variety of different things that might be recommended in either of these pathways. For pain psychology, every patient that is seen by a pain psychologist is then enrolled into the single session class, the empowered relief class. There might be other things that we're recommending for folks because we know that a single session may not be enough for patients that are very complex. But the idea here was, can we give them something that's palatable to sort of orient them to treatment, as well as to give them some very simple skills that they can start to use as soon as they finish the class. That could potentially give them some relief and maybe build their self-efficacy so that they could continue on in more intensive approaches. So let's see, I'm going to skip through this slide. What I was wanting to emphasize in that slide and just demonstrating the treatment pathways is the opportunity we have here to engage patients potentially and to reduce the likelihood that they may drop out of therapy for a variety of reasons. So the questions we wanted to answer is essentially, first, is this feasible to do a class like this to make it standard of care within a large academic medical center? Secondly, does the participation in empowered relief make an impact on the patient's participation in other interventions that are behavioral in nature? Also, what's the acceptability and the utility of the class? So for those patients that do attend, are they finding it useful? Are these skills that they can see themselves using after the class? And then we also wanted to just start to look at the outcomes between those patients that attend the class and those patients that were scheduled but no-showed or canceled. So we summarized the engagement rates in the empowered relief class. We summarized the patient satisfaction. I'll go through that with you today. We also wanted to look specifically at pain interference and pain catastrophizing to see the differences in those measures between people that did not show or canceled the class and those patients that decided to come. And then we wanted to look at the number of visits. We decided to look 3 months before the class and 3 months after to see, did patients have more or less? So the patient population that we're looking at are adults 18 and older. These are all chronic pain patients seen within our center. The empowered relief class, as I mentioned, I'm not going to go into too much detail about what that involves, but essentially the role that it serves is to teach patients some very easy to implement skills that they can start to use in the immediate to make a difference on their pain. The project was reviewed by the Cleveland Clinic IRB, and it was given exempt status, basically looking at this as a clinical improvement project. So in terms of patient satisfaction, we deployed a e-survey. It was 7 questions for every patient that went through the class. They received this survey through MyChart, where they were asked a variety of different questions to assess the acceptability and the utility of the class. There was also an opportunity for them to provide some feedback that was free text in nature. The survey was sent only to a subset of the patients that completed the class. As I noted, we started this pretty much very quickly when COVID kicked into gear. And then later, about 4 months after we started the class, we actually started to use this e-survey to look at the satisfaction. Okay, so the good part, the results. So we looked at a 12-month period from January 2021 to December 2021. We found that of the 221 people, or the 307 people that were scheduled for the class, 221 showed up. They decided to come to the class. That's a 72% engagement rate, which is high. Very good with the chronic pain population. And again, we're looking at those very complex refractory patients. So for the patients that completed the class, we did see nice improvements in pain interference and pain catastrophizing. We did not see any changes in those people that were scheduled for the class that decided not to come. So we do regularly assess pain catastrophizing and pain interference in all of our patients. So even if they decided not to come, we found that they didn't have any impact. So the other thing just to note here is that the patients, and I'll get into the engagement data here in a minute, that decided not to come to the class, we found that those patients really didn't come to many other appointments, behavioral or otherwise in nature. So that did limit somewhat our ability to look at the pain catastrophizing and the PROMIS interference scores because they weren't completing those questionnaires either. This is a slide just overviewing the demographics. These are the patients that you can see the differences between the patients that completed the empowered relief session and those that no-showed or canceled the session. The average age was 51. It was more likely that the patients were male and lived in a zip code with a higher median income if they attended the class versus those that did not. This slide just gives you a bit more information about the PROMIS pain interference scores and pain catastrophizing scores. On the left, those are those that completed the empowered relief session, and on the right, they no-showed or canceled. And in terms of class satisfaction, we had a fairly low completion rate for the satisfaction survey, and this is relevant. So it was a 26% completion rate. Only 38 patients that actually attended the class decided to fill out the post-class survey. Couple of reasons that this might be happening. One, there's no incentive to complete the survey. Second, our MyChart system through the Cleveland Clinic, we use it abundantly, maybe too much to communicate with our patients. So the thinking here is that they're just habituated to receiving so many messages. Why would you open another one? Or, maybe I'm just tired of responding to these messages. So one thing we've learned is that probably is not the best route to try to get this information. Maybe we can look at giving some sort of satisfaction survey in real time while they're in the class, and that might help with engagement. But what we did see from those people that completed the survey was good. We saw that these folks were satisfied on a 1 to 10 scale. The median number for all the questions was an 8 or a 9. And the largest mean was for the question, how likely are you to use the skills and the information you learned? This is really important. They attended the class. They felt like, you know what, it's fairly likely that I'm going to use this after I leave today. Now, what about the impact of the class on visits? So we kind of thought that those people that attended empowered relief might be more receptive to additional pain care. We also wondered if there's those folks that are maybe more contemplative about this kind of treatment approach, if it would make them more likely to want to attend another session or to engage in an intensive functional restoration program. Essentially, what we found is that those folks that decided to come to the class, they're engagers. They engage in more care overall. They engaged in more visits before and more visits after the class. However, in those folks that no-showed or canceled, they didn't attend many appointments before or after either. So we have engagers and we have non-engagers. So the takeaways here, first of all, this is the first pragmatic application of using empowered relief in a large medical center. And we found that this was feasible, that patients bought into it. We had really good engagement rates. So I think this is really promising. We also found that those people that are engagers, that are receptive to just even attending an appointment with a pain psychologist, are likely to continue to engage in this kind of care. There definitely were some limitations. We had that low survey response, which we hope to be able to improve in the future. So there is the likelihood that there's a selection bias. We also didn't look at other treatment variables. We have to account for that. And so there's really some unknowns here, more specifically about those people that did not engage or chose not to attend. And this is something I think an opportunity for the future to look at. We do see that empowered relief is an easy solution to offer to those that engage in treatment and potentially can give them skills that they can use in that moment to be able to help them immediately after the class. Future research, potentially we could look at the predictors of non-engagement or factors that might be involved, such as depression. And I think there's still questions, what patients are best suited for brief behavioral intervention, such as empowered relief. So we're really excited about what we have found, and more specifically about how our patients are engaging with this intervention. I think there's more to be done in the future. Thank you.